So moving to the next excellent star speaker for tonight, and we're going to speak about regional anesthesia, which is another interesting field, and also interesting to have regional anesthesia in the ICU. It make a difference rather than giving sedation and trying to give regional for our patient. I think that's the era in the ICU. It is my pleasure to introduce Prof. Nabil Elkassabany. He is Associate Professor in the Department of Anesthesia and Critical Care, University of Pennsylvania, and he's the director of the sections of the Orthopedic and Regional Anesthesia. He is also the fellowship leader and the director of the Regional Anesthesia and Acute Pain Medicine, and the director of the Ambulatory Surgery Center at University of Pennsylvania. He is currently the chair of Regional Anesthesia and Acute Pain Medicine Education track at the ASRA, and he's a board member of the American Society of Regional Anesthesia and Pain Medicine. His research interest focuses on improving patients' outcome after regional anesthesia and the questions related to the orthopedic anesthesia and acute pain management. And he's going to take off us tonight for an excellent presentation regarding use of regional anesthesia and analgesia for the major ortho surgery from evidence-based to value-based practice. We are delighted to listen to you, Dr. Nabil. Thank you so much for your time. Please go ahead.
Well, thank you, Dr. Amr. Really, thank you, Dr. Amr. Thank you, Dr. Saad. Thank you for the entire family of the Mega Online Learning platform for the kind invitation. I've been lucky enough to watch the growth of this platform, over the past, I don't know, maybe a year and a half or a couple of years. And really, the growth has been exponential. And it's really a testament for the effort that everybody who is supportive of this platform is working on. And to me, I was excited to come here because this is the ultimate embodiment of how a grassroots movement can really contribute to physician education, not only in a specific country or who belong to a specific society, but to physicians across the globe. So very commendable effort. Thank you. However, I have to say to Dr. Saad, really just having me following, Dr. Rodriguez Vega is really a major task. I don't know how can I follow, such, a great talk. I think, this is going to be a major task, but we'll do our best. And I'm also, proud to say that I have chaired the ASRA meeting in 2020 that was in Orlando. And I am the track chair of the Regional Anesthesia and Acute Pain Medicine. And I'm taking some of the points that Dr. Rodriguez have been talking about to heart, and really maintaining the balance in every single panel and every single submission that we accept. And I hope that you guys now are even noticing that on the different platforms and the different meetings that you go to. So without further ado, let's just dive into our topic today. So this topic is really near and dear to my heart. I'll first have to start by saying I don't have any financial disclosure. The only disclosure I have is that I'm one of the directors and the board of directors of ASRA, the American Society of Regional Anesthesia. I put up my email. If anyone has any questions, please forward your questions to me. I also put my Twitter handle. I'm usually very active on social media, and there's a lot of usually very scientific discussion that happens on some of these platforms. And I will have to tell you that patient and physicians have consented for the images and videos to be used for educational purposes. So I'll have to start off by really just telling you who I am. All right. I am really a graduate from the same medical school that Dr. Mahdi came from. And this was me, when I had a lot more hair and I was probably 100 pounds lighter. And this is my older son now, he just got recently married and he finished school. And I'm really a very proud graduate of Alexandria University. And I'm in debt to all those who contributed to my education over the years. And I think I'm here now speaking to you just because of the effort of every single one of these greats. So my journey started from Alexandria and went across the Atlantic to Baltimore, to Hopkins. And from Hopkins, I went down to the Cleveland Clinic where I did my residency, down to Florida, did my fellowship, and I ended up in Penn, and I've been Penn for the past 10 years. Today, I'm talking to you from Philadelphia. Philadelphia is a city, it's in the northeast part of the United States. And probably some of the iconic features in Philadelphia is the Art Museum. You're probably very familiar with the movie Rocky, like when he was running up and down stairs. This is probably one of the most iconic features in the city. This is the Liberty Hall and the Liberty Bell, the Kimmel Center. It's really a city has a lot of culture. A lot of times, like, you know, when I take a stroll on the Schuylkill River, just reminiscence of the Mediterranean and, like, you know, where I grew up back in the day. This is the look from the helipad. Okay, I work at Penn Presbyterian Medical Center, and really the center I work in is mainly an orthopedic hospital. So we treat, like, you know, the entire spectrum of orthopedic surgery, whether it's elective or trauma. And what we are trying to do with you today, that we're trying to discuss the value of regional anesthesia in one of the major orthopedic procedure, which is a total knee arthroplasty. And really, how can this be weaved into some of the enhanced recovery protocols? And we're going to discuss some of the elements, the evolution, and the personnel and resources needed to implement that model. And we're going to define some of the outcomes that needed for the ARAS protocols. I usually learn to put the take-home messages in the forefront of my talk in case somebody has to leave, so that what I want to convey to you at the end of this talk, that regional anesthesia and multimodal analgesia are core components of the ARAS protocol. And I also want you to leave with the message that the fast-track protocols are multidisciplinary. You have to work within your own system and break the medicine silos. And also the ARAS protocols are about improving patient experience. We are really, most of the time, focused about the length of stay, but really length of stay is not the holy grail of the ARAS protocols. So now, what does that mean? Like, what is ARAS? You probably have seen that, like, so many times in so many lectures. And the definition, it's just a multidisciplinary, patient-centered, evidence-based perioperative protocols to improve patient experience and to improve perioperative patient care. Today, the protocols have been developed as a procedure and disease-specific scenarios. And the ARAS protocols seek to reduce the physiologic responses to surgical insults and improve patient perioperative experience through a series of coordinated perioperative interventions. Well, that's all well and good. So what is the hype about ARAS? Some of that hype is so far that we have about 1,600 articles about ARAS since 2000, and half of them were published after the year 2015. ARAS main focus is about patient experience and reduction complication. But nowadays, like, we see a major shift that everybody is mainly focusing on the length of stay and ignoring the main purpose that this was put together for. And usually everybody talk about ARAS as just one set of criteria, one set of intervention, but we have to understand that ARAS is not a one size fits all. And from the website of the ARAS Society, you can just read that the immediate challenge to improving quality of surgical care is not discovering new knowledge, but rather how to integrate what we know into our practice. So what does that mean? That means that we are not going to come up with a new knowledge or new criteria for how to take care of patient. We are essentially going to organize our effort and just bring the evidence that we have to serve that patient and improve their preoperative experience. So with that, like, we should first look back and see what is that we know. So what we know, that when you use regional anesthesia, you're going to improve patient outcome, you're going to improve pain control. It may result in decreased length of stay. It may improve, like, patient functional outcome, whether you're talking about total knee arthroplasty or total shoulder arthroplasty. And it also may improve the quality of recovery and quality of life after different surgical procedures. And it also have positive physical outcomes in both the ambulatory setting and the inpatient setting. And when it comes to that, let's just pause for a minute. So we know that most of the income, at least, like, I think this is a global phenomenon, not only in the United States, that most of the income for the hospital comes from the operating room. About 61 to 75% of the income and the revenue of the hospital comes from the OR. So whatever intervention that you do to increase the throughput through the operating room, decrease the length of stay, saving a 1 night of stay on the ward in a way that's going to increase that throughput is going to increase the fiscal bottom line for the hospital and for the administrator of the hospital. And this is some of the strategies that you can use when you negotiate, like, you know, some of your requirement of the resources that you ask for with your hospital and hospital administration. You have to be very cognizant of that. So when we talk specifically about the knee arthroplasty recovery enhancement, or the acronym, at least in our place, like we call it the CARE protocol, we're going to talk about how did we go about implementing an effective change, and what is the main component of the ERAS and the evolution of the MP3. And the MP3 is mainly the acronym for a multimodal perioperative pain protocol. And also we're going to show you some of the collaborative models that we put together throughout the health system that I think can be a beneficial model for anyone who's listening to this talk. So as humans and as physicians, we are really very apprehensive when it comes to change. We are not, people embrace change, like, you know, to variable degrees. So for example, if Dr. Mahdi or Dr. Amr came tomorrow to the administrator of the hospital, said, like, I'm going to implement, like, you know, RAS protocol tomorrow for knee arthroplasty or shoulder arthroplasty, I'm sure that they're going to meet a lot of resistance, and a lot of people are going to be asking, like, what, are you going to change our ways? Like, you know, we're doing fine. Why are you doing this? So I think my advice or my recipe for that is usually first thing that you have to assemble a team of stakeholders. You have to see who really are the stakeholders who are taking care of this patient throughout their preoperative journey. And always when you propose a change, don't propose a very radical change. Propose a change in form of a pilot, whether it's 20, 30 patients, or propose a pilot over a certain period of time. And before proposing the pilot, you have to know very well, what are you measuring? What are you planning to change? Why are we doing this? And this is key, because when you say that, why are we doing this? You have to measure these outcome metrics before and after implementation of this pilot. And then you have to measure and then compare. And after you compare, you essentially have to show off your results, brag about them. And then comes the last stage of that is how to scale up. When in the business school, when they talk about the bootstrapping, there has to be a lot of hustle, like, you know, in the beginning to put this pilot together. And the other thing is just you have to have what we call the minimum value product. This is essentially the result of your pilot that you have to take it and to the hospital administrator. The first point in this implementation is how to put together the team of stakeholders. If you think about who's taking care of patients who's having total knee arthroplasty, this is your surgeon, this is acute pain service, this is the pharmacy, physical therapist, the hospital administration, like, you know, the home care, health, and nursing. Just have everybody around the table listen. Okay, as a leader of the perioperative care, you have to be a good listener. You have to listen to the goals of these folks. What do they want to achieve, like, you know, from taking care of that patient, and how do they define success in their day-to-day mission? So some of the metrics for a protocol like this is going to be the length of stay, the readmission rate, the pain scores. This is what we call the outcome metrics. The metrics the other flavor that comes in, it's a process metrics. And this is going to show the compliance to these protocols in terms, for example, the number of modalities of analgesics used. Did you use only non-steroidal anti-inflammatory, or did you use non-steroidal anti-inflammatory, regional anesthesia, local infiltration, and acetaminophen? What is the adherence or compliance to the protocol that you put together? Is that in a percentage? And also you look at the opioids used. This is also one of the process metrics. But when you do that, you have to essentially be very cognizant that you have to put together what we call a set of balancing metrics. And what these do is essentially is going to try to ensure that no intervention is going to be overwhelming to other outcomes. For example, that our goal is to reduce opioids. We're not going to reduce opioids to the amount that the patient are having their pain not well controlled. So that's why that we have to put a balance in metrics to make sure that the patient is still as comfortable as possible. This is what we mean by the balance in metrics. And also the other thing that you have to know in terms of the process, you have to know exactly what the patient go through. You have to define or chart the patient journey. So each one of these boxes that you see on the screen, this is a touch point for the patient throughout their total knee arthroplasty and throughout the journey. And there is a perioperative provider who get in touch with that patient throughout this perioperative journey. And we have to know what exactly he or she is doing to that patient and how can we improve and how can we help them just improve the process as the patient just move through this. And this is how we can intervene. When you put together, like, most of the drivers of the ERAS protocols, you're going to see that actually you and I, as an anesthesiologist, this is the core of what we do. Most of the intervention is going to span the whole preoperative continuum, whether it's preoperative, intraoperative, and postoperative. And moreover, you're going to see the multimodal analgesia and the regional anesthesia is going to stay with us from before surgery, during surgery, till after surgery. There is also a couple of elements that we're going to talk about that I think we can contribute to in a great deal, including but not limited to patient identification and defining patient expectation and educating patient about the different intervention that we are going to do for them. This is a summary of what we call, quote unquote, our recipe, what we do for our the knee recovery enhancement protocols. And you're going to see, like, we do nerve block, we do local infiltration. Most of our patients get spinal, we use tranexamic acid. I am not going to go in depth into the description of these elements. I actually would rather focus on the process and try to give you a recipe, give you some tools that you can go back and implement some of these protocols in your own hospital, or possibly see if you can improve on the process that you have. But I'm sure most of you have something very similar in your hospital. So this is not rocket science, or this is not a breakthrough in the invention. It's just like, putting all these interventions together and having almost a quarterback who's going to guide and regulate like these intervention one next to the other. One of the things that is very important in the whole program of the ERAS is patient selection. And what we do in our institution, we use something called the Risk Assessment and Prediction Tool, or the RAPT tool. And this score is essentially, you ask patient, and the total score that they can get from a different question is out of 12. And if the patient scores above 9, their functional status would qualify them for a shorter length of stay. And they don't have to be admitted to an acute nursing facility or acute physical rehab, and they can rehab at home. And this is the patient who we're mostly target for most of our intervention. Patient education is something that is very, very critical. Although University of Pennsylvania is a major institution in the United States, but guess what? Like, we actually do not have a perioperative clinic. So we meet patients only the 15 minutes before surgery. And with that, we learn to make do with what we have. So what does that mean? That I don't have access to that patient. So my options, and I want to still do some education for that patient. So we put together some educational material, we put it as pamphlet, and these pamphlets are included in the patient surgical package when they sign up for surgery, and they can go through it. We have printed materials. We have also printed materials as an instruction for the ambulatory pumps that they're going to go home with, that they were going to learn about. And even we have some QR codes that we came up with. And these QR codes are going to take the patient to some of the educational videos about the ERAS protocol, about the pumps that they're going to use for postoperative analgesia, and hopefully it's going to give them the whole dimension. If the patient is tech savvy enough, there is an app that our joint service uses. It's called the Quill app, and it just takes total knee arthroplasty and make it a journey. So, for example, a patient would sign for a total knee arthroplasty, and in 4 weeks, they send the patient, talk about rehab, talk about the importance of physical therapy and the importance of exercise. When it comes to 2 weeks, they're going to talk about preparation of the home, that they should prepare maybe possibly a bedroom in the first floor so they don't have to do a lot of stairs going up and down. They're going to talk about the different options for anesthesia. There are some videos that I'm going to show you a sample for that the patient is going to watch on the app. And this is essentially staged. And even after recovery, like, the first day, like, a week from surgery, 2 weeks from surgery, is going to push information to that patient and just walk them essentially through the entire process. And this is like, a set of videos that is here. And I'm just gonna pause sharing for a second, right? I want to show you like, one of these videos just as a sample. We're not gonna see the whole thing, but I want to show you that this is what the patient sees, for example, when we talk to them about anesthesia.
Blood pressure, okay?
There's been lots of advances in joint replacement, but the biggest improvement, I think, has been the anesthesia or the pain relief that patients experience.
We have a lot of evidence that support the use of regional anesthesia versus general anesthesia, especially in the population of the total joint arthroplasty. Regional anesthesia essentially entails providing the anesthesia for the part of the body that we're operating on. I personally prefer regional anesthesia for this procedure for the following reasons. We're going to potentially avoiding general anesthesia and some of the potential side effects for general anesthesia. You're going to be more awake immediately after surgery. You're going to be able to sit. You're going to be able to eat and drink quicker. Not to say that general anesthesia is not safe.
Yeah, so you get the idea. Like, this is like, some of the videos that the patient is going to see. So we're going to go back to our presentation here again. And I can provide links for anybody who really wants to see samples of those videos and like, want to see like, how these things work. Okay. And also they're available on the website if the patient, again, is like, savvy enough to just browse these videos. Our patients, like, they used to sit for a half day during class, like, before we came up with the app. And in terms of just translating, like, what we do and our practice into evidence-based, we looked into the effect of attendance of this joint class on the patient choice of the type of anesthetic. And we found that patients who would attend the joint class are going to be more likely to choose the type of anesthesia, which is essentially spinal anesthesia versus general anesthesia in those who did not attend the joint class. That's why the effort of improving and increasing the content of the joint class has been like, a paramount goal for us. This is our multimodal protocol, again, which I'm sure that most of you are very familiar with it. We're not going to spend like, a lot of time doing that. But what I want to go through is really the journey of the evidence base and how to translate our practice from evidence to value base. So when I took over the division chief in 2012, essentially our practice was a la carte. Every surgeon, like, would have their own preference. One surgeon likes spinal, another one likes general. Somebody likes blocks, somebody does not like blocks. And what we did exactly what we talked about in the beginning of that talk. We had everybody sitting around the one table, and we want to come to a consensus. And again, surgeons are our friends. And I say that like, with some smirk or some grain of salt, but they're still our friends. And we have to listen to them. And we don't work in silos. And we see like, what works for everybody. And we try to really come up with one protocol that everybody have a consensus on. So initially, what we agreed on that we're going to do multimodal analgesia and we're going to do continuous femoral nerve block for everybody. That was our protocol in 2012. And then came along the adductor canal block, pretty much replaced between the years of 2012 to 2016. A lot of publication came about adductor canal block and pretty much replaced the femoral nerve block as for analgesia of total knee arthroplasty. So our choice was to move to the adductor canal block. But before we do that, we decided to examine the evidence in a critical way. So the question that we have is really the adductor canal block equivalent or non-inferior to the femoral nerve block? Now, when you look at the literature, you can find some literature to say, in terms of the analgesia, they are equivalent. Or you can say, actually, you can find some literature that says the other way is going to say that the femoral nerve block is superior to the adductor canal block. And this is the evidence in red. But the question I have for everybody, if the adductor canal block, if we assume it's not a complete block, does it have to be? Does it have to be a complete block? And the answer, maybe it doesn't have to be a complete block. Because if we're given that in the context of multimodal analgesia, we have a lot of supplements that can supplement the regional anesthesia. And we're not going to rely on regional anesthesia as a sole tool for analgesia for that patient. So we have a lot to supplement. So maybe it doesn't need to be a complete block if there is something that we are gaining. If we are gaining like more motor power, if we are gaining better functional recovery for that patient, maybe the adductor canal block at that point is going to be a better tool for us to use for analgesia. And then here it comes when it comes to the functional outcomes, whether it's some evidence to support that the adductor canal block is better. And actually, like, one paper that we did, when we're looking at the falls, essentially, and we looked at the performance in physical therapy, we found the adductor canal block was equivalent to the femoral nerve block. And the rationale from that was the quadriceps. There is going to be a lot of reasons the quadriceps is going to be weak after surgery, with or without blocks, and we're going to go through that. So falls, patients who have orthopedic surgery are going to be likely to fall with or without block, about 1 to 2%. However, when you have a weak quadriceps, this is going to be contributing to the incidence of falls in these patients. One of our friends from the Hospital of Special Surgery back in 2014, Stavros Mantisudis, he looked at the Premier database, and he found actually there is no association between falls after total knee arthroplasty and the administration of peripheral nerve blocks. We took that and we ran with it. We conducted a study to assess the risk of falls when you give femoral nerve block versus given adductor canal block. And we found actually the risk of falls was pretty much like similar between both the femoral and adductor canal block. However, just for the sake of complete honesty and reporting, we found that the quadriceps motor power was preserved in the group that has the adductor canal block versus the group that has the femoral nerve block. And that was the main trigger of us to switch our practice from the femoral nerve block to adductor canal block. So now our practice is the multimodal plus adductor canal block. Now, the second question that came after that, how long should we keep these catheters? Or is a single shot is enough? We decided to do what? Yes, we decided to do a study. And we partnered with what? We partnered with our orthopedic surgeons. So our study that we did to follow was essentially comparing a single injection versus keeping the catheter for 24 hours versus keeping the catheter for 48 hours. And we decided to look in a very scientific way to our data. And we find actually some signals to point that keeping the catheter for 48 hours is going to result in better pain outcomes in these patients, better than the patient if we kept it for 24 hours or patient who get a single injection. And this is how now we come with our protocol that this patient at least are going to keep the catheter for 48 hours. Now, the other thing, the next thing, I think there is somebody has questions. Are we keeping questions till the end, Dr. Saad, correct?
Yeah, correct. The end. All questions at the end.
Okay.
Thank you.
You're welcome. So the other thing that came about, also more recently, is the IPAC, and whether should we add the IPAC to our protocol or not. We decided again to do a study with that to see if adding the IPAC is going to be something useful or beneficial or not. And actually, we found that it was beneficial. We just essentially presented that patient with the chart that you see, okay, and we did the IPAC on one group. The other group has a sham block, and we just simply asked the patient at 0, 6, 12, and 24 hours whether they have pain and where is that pain. We asked them to define it, whether it's in the thigh, anterior, inner, outer, or in the back of the knee. And we found our primary endpoint with pain in the back of the knee at 6 hours. That was our primary endpoint. So now our protocol includes the multimodal analgesia, the adductor canal block, and the IPAC. We switched that in 2018. And we still with the question of the utility of the femoral nerve block versus adductor canal block. So one of the things that we did, and we presented that work in one of the ASRA meeting, is essentially doing the femoral nerve block, especially in patient with chronic pain or patient with revision knee arthroplasty. This is a patient who comes already and using a lot of opioids, because most of the evidence that we have has been really abstracted for patients who are opioid naive and they don't have any previous pain history. So that was the work that we're doing currently. And the whole idea or the whole thought process behind this is to really have a paradigm shift in terms of postoperative analgesia from giving opioids, and more opioids to furnish a baseline of multimodal analgesia and possibly maybe add a layer of regional anesthesia. And if the patient needs opioids after that, you're going to get their opioids. We're not anti-opioids. We say that opioids are very helpful agents if they used appropriately for the right amount in the right context. And the whole goal, that we're going to get to that point.
I'm going to test the strength out of your left leg. Keep it planted on the ground. Now with your right foot, walker, basically step forward. Take some weight off the leg if you need it. You're trying to control that leg, not have it buckle. To make the movements nice and smooth, all right? Straight down the hallway. This way? Yep. Left turn. And then step to the side with the right foot. Good. And now.
Very nice.
Good.
So the timestamp on that video is 11:30, and this patient was done at 7 o'clock in the morning. And you see, he's walking, and in about a couple of hours, he's going to get dressed and he's going to go home after he does his steps. Right? And this is the whole idea. To me, this is the value. We're all working for that. Now, after we do this, the main question is how to scale this up. Really, now that we have our pilot, we have our the minimum product that we have. Now, how to scale this up? How to automate this process? Now, I work with electronic medical record. I am very aware that there is a lot of places around the globe that they don't have the same thing. But really, at least in our environment, what we did, we implemented an order set through the electronic medical record. We ordered just flagging patients, so every perioperative provider would know that this patient is going to be a candidate for the ARAS protocol for the knee. And all what it takes for the provider is to really click on the flags, that is included in this patient. This is how we identify the patient. This is a flag that I'm talking about. And all what it takes is to really just for the provider to click that flag, and it's going to take them to a link that's going to tell them exactly the steps that he or she has to do, and essentially taking the guesswork, out of the ARAS protocol. So nobody said, "Oh, what do I do for that patient? What do I do for that patient?" No, we're just going to be very explicit and be very open about explaining the different steps of the ARAS protocol. One of the things technology-wise that we try to implement is to really follow up on that patient through a texting platform. So we're texting that patients after surgery with a set of questions, asking them about their opioid use, how comfortable they are. And really, we learned that a lot, especially during COVID. So during COVID, when the patient goes home with these catheters, you see that we learn how to follow up this patient through a telehealth mechanism. And I'm going to just show you a sample of what we do here, with
2019, the Regional Anesthesia and Acute Pain Service at Penn Medicine decided to experiment with telemedicine. We discovered that patients and nurses prefer to see the provider rather than just hearing from them on the telephone. Throughout 2020, using a combination of switchboard as well as blue jeans, providers and patients were able to connect remotely. Especially relevant during COVID, rather than having an entire team round on a group of patients, a single member of the team would round with the iPad and remotely connect with the provider. In addition, nurses were able to connect with the provider and allow for a face-to-face conversation with the patient directly. Providers could evaluate the catheter site and have a direct consult with the patient, even if they were not available at that moment to come round. An additional platform for communication with patients is known as Way to Health. This is a text platform that allows us to communicate with patients directly. Patients receive a text message every day from the hospital asking them how their pain is. They complete a series of questions, which prompts them to take the next step in managing their care. If they rate their score above a certain threshold, they are notified to contact their provider immediately. Additionally, it helps keep track of the amount of opioids patients are using. The following is a clip of a real-life consult. Permission was obtained from the patient to use this video for educational purposes.
Hi, I'm Dr. Grosh. I'm one of the anesthesiologists. How are you?
I am doing pretty good today.
What surgery did you have done today?
I had a right knee replacement is the term they use, even though it's not an actual replacement.
Got it, got it. And how are you feeling today? How are you doing with your pain catheter?
I was told it would be worse tomorrow. It's unpleasant, but it's bearable.
Good.
I did walk around the room with the therapist.
Great.
The provider then asks the advanced practitioner, resident, or nurse taking care of the patient to get a closer look at the catheter and make sure that there's no redness, induration, swelling, bleeding, or leaking of the catheter.
The person that's holding the iPad, are you able to see any sort of redness or irritation around the site?
No.
Okay, awesome.
Utilizing the same technology used by intensivists, a busy pain service is able to provide more immediate access for patients to their provider, especially in a large health system that covers multiple sites. The advantage of virtual meeting is eliminating the need for commute. It can also help improve the staffing model. As virtual platforms evolve, technology and resolution will only improve, making this much more ubiquitous. 2009.
Okay, so that you got the idea. So now this is ERAS, and ERAS is great. So really, what is wrong, with any ERAS protocol? What we have found, over the year, that we always, when we said let's do ERAS, we usually put a lot of intervention together, and we put a lot of the niche drugs, the new drugs that comes to the market, we add it to the protocol without really testing or without an evidence base to support that. And what we found, there is a ceiling effect for any outcome that you measure. No matter what you add from intervention drugs, that outcome measure is not going to move. And it's going to be very hard to attribute the addition, whether it's to this drug, to drug A, or to drug B. And once you add one of these interventional drugs to the protocol, it's very hard to take it out. So this is something that we have to be very cognizant of, and with the intervention that we add. The other thing that we have to understand, again, I have been touting this over and over, that ERAS is not only about decreasing length of stay. It is mainly about improving patient experience and decrease the physiological insult that results from surgery and anesthesia. One of the governance model, I'm just going to go very quickly over it to just give you an idea of how things happen here, that we have this pyramid of governance. So you have the ERAS team, you have a panel of experts, and then you have leads from both the surgery department and the anesthesia department. And then you have executive sponsor on the hospital level. And this is afford us essentially the quality metrics, afford us some IT resources that we are able to get, universal order set, that we're able to publish the different protocols. And also we're going to create the dashboard. And the dashboard has been something that I am personally very proud of. This is how we collect our data. So any patient who have surgery, whether they are part of the ERAS protocol or not, is going to be entered into this dashboard. And you can see here the filters that we can put by the hospital, by the surgeon, by the CPT code, by the surgery that they have. And we have defined a priori 6 outcome metrics to measure, including the opioids, the carb loading, the mobility metrics, and some other metrics that we can measure and define. And if somebody really wants to dive more, we can give them a detailed report, and they can go to the chart, the electronic medical record, and really get more detailed information about these patients. So this is essentially how we collect our data, and this is how we are able to come up with some of the results that I'm going to show and share with you. One of them, for example, is the compliance with the opioid prescription in the state of Pennsylvania and the state of New Jersey after ERAS protocol in different fiscal years, from 17 to 19. And this is exactly tells us through the Way to Health app that we talked about, how much opioids did every patient use based on the different services. This is not only knees. You see here shoulder arthroplasty, hip arthroscopy, complex knee arthroscopy. This is any patient who's having any surgery, that I am able to tell exactly how many opioids this patient has been using after surgery based on the intervention that I do, and whether I can improve on what we do on my practice. Also, I can see my length of stay. I can see the discharge home, how many patients got physical therapy on postoperative day number 0, and how well did they do. And again, being data driven is really what's going to add value to your practice. We get very excited about regional anesthesia. We get very excited about the techniques. I know that we're all have our own biases, and I love regional anesthesia. I love for lack of better description, sticking people with needles. But again, there is something beyond that, something to be said about how can I improve that patient experience with every block I do. So more than the block, think before you stick anybody with any needle, think about what value am I adding to that patient and how can that translate into data that will support my practice. If anything, this is the message that I want to leave you with. Again, regional anesthesia and multimodal analgesia are critical component of any ERAS protocols. Multidisciplinary is a beautiful word. Just break the medicine silos, talk to surgeons, talk to physical therapists, talk to nursing. And ERAS is not only about decreasing the length of stay, it's mainly about decreasing the physiological insult to surgery and anesthesia and improving the perioperative experience. And again, this is my sentiment about anesthesia. Anesthesia to me, this is hours of boredom, minutes of thrills, and seconds of terror that I do not wish on anybody. And I'm going to be more than happy to take questions. I'm sorry I ran a little bit over in time, but you guys have been very generous, and thank you very much.
Thank you so much, Prof. Nabil. That's really very fantastic conclusive presentation. Really very impressed with the practice you have in your hospital. The change, Prof. Nabil, is always difficult, and I'm sure you had faced lots of difficulty. You came in 2012, changed your protocols that had been implanted there for years and years. So can you tell us what was the most challenging factor you find when you were trying to implement a new protocol? And then I will hand over to Dr. Muhammad Mustafa. Thank you.
I will, Amra, I will be very honest with you. I think the most challenging was people, and how to change the mindset of whether they are surgeons, whether they are hospital administrators, and you have to learn essentially to speak the language of each one of these people. And you have to know what really gets them motivated and what really is a driver for them. So for surgeons, for example, and I'm gonna digress here a little bit, okay, for surgeon, what's important for them? Quite honestly, important for them, yes, okay, good outcomes for patients. Okay, this is what we all know and what we agree on. But quite honestly, if you tell them I'm gonna give you outcome, but with every surgery, I'm gonna essentially push you back time-wise about 45 minutes to an hour. Nobody's gonna just allow you that luxury of time, right? So you have to be really very cognizant when you design your protocols of really being very aware of what motivates everybody. When you talk to a hospital administrator, you know very well what's gonna motivate, he or she is essentially the bottom line, is the dollar. When you talk to them about the bottom line, the fiscal bottom line. I'm gonna save you length of stay, and that length of stay is gonna translate into that many dollars or English pounds, okay, just into it's gonna cost that much, and this is how much I'm gonna save you because we do that many cases a year. When you talk to a patient, you talk to them about being comfortable and control and just this, so you have to talk to everybody with their own language. I think this was the most difficult part, is to really be honestly a good listener.
I'm so impressed that Prof. Nabil, you had backed up your point with the research. So you were able to convince the surgeon, because really to bring whole surgeons to agreement is a very difficult, especially they are practicing their surgeries for years and years. They have their own experience to change their practice and come to agreement. And then you back up your point of view with research. So you proved what you are saying. That's all for the benefit for the patients. That's really fantastic. Thank you so much. Dr. Muhammad Mustafa, please go ahead. Thank you.
Hello, Dr. Nabil. Really, it's great pleasure to listen to you. It's fantastic, really fantastic presentation as usual. And I'm personally I'm biased because I'm really I'm a big fan of your tweets and all your recommendations and all your activities being here. I know that it's around 2 o'clock now in the United States, and we are here at the end of the day. We've been flooded by about a lot of Halloween visits, but I'm impressed by the amount of, especially the amount of research and amount of the recommendation regarding the ambulatory and outpatient regional anesthesia for orthopedic, and yes, it's it's quite painful operation, isn't it? And always the pain, always it causes lack of mobility, which is get the patient into vicious circle of increasing length of stay with the pain. And you know, in the British standards here, we have the standardized protocols, which everyone gets stick to it, and we like the one size fits all protocolized way of managing major orthopedic and trauma, and all the ERAS protocol. Really, we are in our hospital, we keep following what we call the Caledonian protocol, which we are using the dexamethasone and the type of analgesia like non-steroidal, involving more and more of the local infiltration. So when I first came to our hospital here, there was no any nerve blocks being involved in especially with the knee surgeries. We have a local, mainly local infiltration cocktail and spinal anesthesia, and only spinal anesthesia without any additional neuroaxial opioids. My personal question for you, Dr. Nabil, because I want just to invest this opportunity here, and thanks for Dr. Saad for giving us this nice chance. I know there's every day there's a lot of tens and tens of blocks being introduced in hips and knees and shoulders, and there's a lot of techniques, not only for one block, it's also for example, for the knee, you have, like, for example, for one block, you have, for adductor canal, you have like a proximal and mid and distal, and then you're involving the popliteal plexus, and then someone comes and do the IPAC, and then someone's do the, just do selective tibial. So what do you think it could be from your institution, Dr. Nabil, could be a simple recipe? Are you doing only an adductor canal as part of with total knees for all patients, for primaries, especially for primaries? Are you doing adductor canal block single injection with and then catheter postoperative? Are you doing? Are you involving the surgeon to do also local infiltration, analgesia on the top of that, or you are doing, because with the IPAC you need to inject larger volume of local anesthetic. Are you? What's your recipe? What's your personal recipe for using that?
Yeah, thank you, Dr. Muhammad. I really appreciate the questions. I'm gonna show you here, right? Where is it? It was like one of the slides here, right? And yeah, here. Oh, here. This is exactly like what we use. All right. So just very simply, right? Just we select our patients. All right. We educate them, and we do the IPAC as a catheter in the holding area, and they get a spinal. If they are good candidates to get like a small dose, and I emphasize the small dose of ketamine, they get a ketamine, all right? And the surgeon is gonna do local infiltration. We do the IPAC, or after we do the catheter stays for 48 hours or longer. Mm-hmm. Intraoperative, we use TXA, we use for nausea and vomiting, we use a dexamethasone. We tend to use higher doses of dexamethasone. If the patient does not have uncontrolled diabetes, we're gonna use like pretty much ondansetron, like on everybody. If the patient has any hint of history of postoperative nausea and vomiting, we have very low threshold to use scopolamine. We tend to be very cautious, especially if the patient is elderly, if they have big prostates, or if they have glaucoma. And then after surgery, we also do the MP3. The MP3 is the multimodal perioperative pain protocol that's essentially consistent with what you described. They do their DVT prophylaxis. And there is a program that's now driven by the nurses. It's called the early mobility, because we don't have enough physical therapists to get patient up out of bed and walk. So actually the nursing now has learned to be ambassadors to lead like these mobility programs and to get patient out of bed and to walk them. And we establish criteria for discharge of these patients. So once any patient are able to walk 100 feet, do 4 steps, use the commode unassisted, get in and out of the commode unassisted, they are essentially, they have no reason for them to stay in the hospital. If they are going home in the first 24 hours, or if they're going home the same day, they go home with an ambulatory catheter. They go home with a pump. And that pump, essentially the one that I told you about in the lecture, and our pain service follow these patients in a virtual way through texting platforms, through phone calls, and through online face interaction. I hope that answers your question. And if you have any more further question about protocols, just feel free to email me or contact me through Twitter, and I'm going to be more than happy to discuss much more details as much as you need.
Is the pumps, are the pumps, Dr. Nabil, are the elastomeric pumps or automatic pumps, which is
no, they are not elastomeric pumps. They are automated pumps. They're digital pumps.
Yeah, and the patient going home with these catheters with
correct.
Brilliant. Yep. Yeah, very good. I liked your statement here where when you because there's a lot of and this is good for also for the residents and trainees. Before you stick your needle, you know how was the outcome of your blocks going to make a difference for your patients. And yeah, I have this a lot of time. Yes, let's do this, let's do that, let's do the IPAC, let's do. But it's how it's going to make any difference for your patients. My question is for you, Dr. Nabil, is any validation for especially with the new, I don't know, we also recently we having the type of the chronic pain gigs where they're doing the genicular nerves and all this stuff, which is how's these type of nerve blocks being introduced for total knees, because I have zero really experience for it, and I don't know how it's really validated for use at total knee, because you know it's kind of you just show it to you, that's quite very easy, especially for but it's absolutely for me it's very difficult.
Yeah, it's interesting that you asked that, because the only piece of evidence that I've seen 2 pieces of evidence. There is a case series, I think it's coming from Spain, from Sal Blanche and his group, and another study that was done at Duke, by Jeff Gadsden and his group. And they have been using the genicular nerve block. And I think also there was another retrospective study looking at that. In theory, it works in theory, right? But think about it. It's almost the things. This is almost regional anesthesia is like fashion, right? Everything that's old is coming back, in trend again. Because we're doing all this, we used to do femoral and sciatic. I grew up, and I was doing essentially lumbar plexus and parasacral sciatic for every knee and every hip. That was the trend. And we started to go lower and lower and lower. So now, we're doing the adductor canal block at the IPAC. Now we're doing the genicular. But why are we doing genicular if you think about it? We're doing the genicular because essentially we realize that actually our blocks are not complete. So I am not going to be surprised at one point that we're going to go full circle back to what we used to do the block that was quote unquote complete, but we have to pay the taxes that we have to pay is essentially the mobility of that patient, and they are very numb and they cannot move. So we try to, I don't know if play is the right term. We try to play with these blocks to some extent, but if you think about it in terms of logistics, these patients, when you do the genicular nerve blocks, so now I do a adductor canal block, I do an IPAC, and I do for the medial geniculate, I'm gonna do superior, inferior, and I'm gonna do the superior lateral, and I'm gonna do the nerve to vastus intermedius. So this is 4 blocks added, and we have the 2 blocks from the beginning. So for each knee, now you're doing 6 blocks. You're sticking that patient with 6 needles, right? So I don't know if logistically would that be even feasible or not. In terms of the studies, I think the evidence is still out there. The jury is still out. When I did it with these patients, honestly, what I did I have this patient, like, I put the spinal in first, and just I do all these blocks because it's almost like torture, like, to keep, like, sticking patient, like, with needle. So I do the spinal first, like, do these blocks, and then just hand it over to the surgeon. Now, please do not take my statement. I'm not advocating for them. Okay, this is still, like, the jury is still out, but our practice is, like, the slide that I've shown. Our current practice is the adductor canal block and the IPAC and the surgeon infiltration. I think for the most part, the surgeon infiltration, if it's well done, it can pretty much, like, cover most of the genicular blocks.
Absolutely, absolutely. Is any difference for this is the last question for myself. So for the surgeons, are they doing because I've seen some surgeons just it ending up the local anesthetic just under the skin and under. Are they following some of them? Are they have a very, very good surgeon in our hospital here? They were doing a local infiltrations before cementing, and you go to the corners. We inject local anesthetic exactly where you can actually target some of these genicular nerves. But it's I mean, like, local infiltration is really work quite well if it's being injected properly. Dr. Nabil, I have some questions also here from the chatting. So Professor Safa is just asking, please, Dr. Nabil, for regional anesthesia is a considered cornerstone in all eras. What about the additives like the narcotics, dexmedetomidine? Is any rule for additives like the Brisidex and clonidine or?
Yeah. So, Dr. Safa, is your question in reference to additives to the local anesthetic or systemic administration of dexmedetomidine or lidocaine? Well, we can answer both yeah. I think if the question is about, like, extension of the duration of the nerve blocks, we might as well, like, if I'm going to do that, probably I'm going to use either perineural or systemic administration of dexamethasone if this is the intent, all right, or prolong the nerve block. If the intent of the dexmedetomidine is to use it, like, in a systemic way, I think it may have a role, but I don't think it really have a major role in orthopedic procedure. I would see, like, that role more in colorectal, in abdominal surgery, more than orthopedic procedure. Honestly, like, we have, like, very good tools that at our hands with the regional anesthesia that will enable us to have that patient, like, very comfortable after surgery. So I think, like, it is a tool, and you're right, like, we can do a lot of things, but that does not mean that we have to do all of them. We have to do the things that really just makes the most sense. I think she's saying something.
Yeah, so I think to the regional as additive block.
Yeah. So this is honestly, like, I'm gonna leave this up to Dr. Saad, but this is almost like, an hour and a half lecture of additives to local anesthetic for blocks. This is gonna be a like, very long, like, discussion. Personally, like, my personal bias, right, is dexamethasone. I am a fan, right, and amongst all the additives, if anything, and we can again discuss that for a very long time, which I think is out of the scope of this lecture. But, like, we can discuss whether it's administered systemic or perineural. But amongst all the additives, I use preservative-free dexamethasone.
Yeah, agree 100%. You use the dexamethasone IV or perineural? Sorry, and you block the Nabil.
Okay, so if I'm using a catheter, right, definitely use it, like, IV. IV dexamethasone is a drug that is very good, and it enables us to do a lot of things, not only prolong the duration of analgesia, but it's helpful for nausea and vomiting. It's helpful for pain, especially when you give it in higher doses. So if you're using a catheter, for example, in a different setting, if I'm using a single child, for example, ambulatory surgery after a rotator cuff or something like that, personally, and we can fight, we can debate, okay, I use it perineural. And I know this probably is not going to be popular with a lot of people, but that's, again, my personal bias.
Yeah. Another question, Dr. Nabil, if for the adductor canal, do you do at which level do you go like proximal, a kind of femoral triangle, or you just you go a bit distal and?
Yeah. So this is, again, that's a very big debate. This is an excellent question, Dr. Muhammad. And I will tell you, just rest assured, that there is a group. That group is about, now it stands at 103 people, 103 regional anesthesiologists, like from around the world, between ASRA and ISRA. And with Tehran, really, there is a consensus going on right now, and trying to define really where is the optimal location for placement and what is the name of that. Is it a femoral triangle? Is it a adductor canal? Like, what exactly are we doing? This is going to be the second part of the major consensus paper that we have about the nomenclature, but this is about upper and lower extremity. So again, logistically, pure logistics, we do this like, with the surgeon, we do it before surgery. So what we agreed with our surgeon, that our catheter is going to be about a handbreadth, like, from the top of the patella. So most likely it's going to be under the tourniquet. So our catheters, I would say it lands somewhere in the distal femoral triangle. I would not qualify our catheter or blocks as a pure anatomical adductor canal block.
Mm-hmm. Yeah, great. In the video where you showed what was the patient himself? What was he in his room or back in house? Is it house or his room?
No, that was in the hospital. Yeah, it was one. Yeah.
So the contact between the anesthetist and the patient was so it's like a digital, but in a different room. So he's
No, honestly, I have to go up and I shot a video of him, and with his permission, I don't do that like for every patient.
That's fine. Again, Dr. Nabil, are the total patient, are the moving day zero? Are the start moving day zero, or are you sending them home next day, or?
Okay, so every patient, about 85% of our patients, they do the physical therapy in the PACU. And actually that was like a big struggle and a major resource drain, okay, for the physical therapy to agree to come and do physical therapy in the PACU. And this was a major undertaking, because that cost us essentially 2 FTE equivalent of physical therapists to be able to do this project. So that's that. We almost have our patient falls into 3 buckets. Okay, the young and healthy bucket is going to be same day. The kind of the bucket that wants to maybe stay like overnight and they're going to go home like in 24 hours. And then the third bucket, this is probably your typical like knee and hip patient who's going to stay maybe for more than 1 night. So we have like the whole spectrum, and this is how essentially when you talk about like the Caledonian Protocol or the NICE guidelines or whatever you want to call it. Okay, I think this is the major difference between how we are taking almost a nosedive into our protocolized medicine versus thinking more globally and think about personalized medicine. Or how can I just think about protocols as a big umbrella, and under this big umbrella, I can pick and choose for what's going to be a good fit for that patient, okay, to really deliver like the best care possible for that specific patient based on their comorbidity and their health status.
Yeah, great, excellent. Really, I'm really impressed, Dr. Nabil, and
you're just so kind.
It's too difficult, honestly. Getting patients. And it's not only, exactly. It's just the logistic about arguing patient about. It's not only about educating patient, about arguing with the multidisciplinary part. It's quite massive amount of parties which you need to involve and get a good outcome. And I agree 100%. That was absolutely amazing, Dr. Nabil. I don't know, Dr. Saad, if we have any questions. Don't want if I keep, I just will keep asking.
I think we have enough for Prof. Nabil tonight, So I think we can follow his. We can follow him, and you can send him question, and he can
and Saad knows how to get.
Don't worry, we'll get all questions to you. And thank you so much.